Hi everyone, I am Dr. Madan Pandian from India. Today we are going to discuss a patient with ilioinguinal neuralgia following a hernia surgery for which we have performed a hydrodissection of the ilioinguinal nerve at the level of the anterior superior iliac spine. Short history of this patient. He was a 65-year-old diabetic presenting with an inguinal for 4 months after an inguinal hernia repair. A continuous dragging pain with episodes of shooting pain along the inguinal region, which was referred to the groin, was present. There was no aggravating or relieving factors, but it was a constant disturbance for his regular sleep pattern. This is how the pain presented as. It was predominantly a continuous dragging pain along the inguinal region. That's the site of the incision for hernia repair. And it was a dragging pain plus episodes of sharp shooting pain along the groin as well. On clinical examination, there was no redness, swelling or warmth. The surgical scar was healthy. The straight leg raising on the right side, which was the side of surgery, was around 80 degrees, which suggested there was no sign of radiculopathy. The SI joint and the hip joints were normal on clinical examination. As discussed earlier, the straight leg raising was around 80 degrees, which suggested there was no sign of disc-related disease, or the Faber test was also negative, which again suggested that the SI joint and the hip joints were normal. Minimum laboratory parameters and imaging needs to be done prior to any intervention. The fasting blood sugar was 140. The patient was not a known diabetic previously. The ESR was within normal limits. Since the patient had a groin pain and the inguinal pain, he need to be evaluated for a facet joint arthropathy. The X-ray of the LS pain was normal. The important differential diagnosis in this patient is an ilioinguinal neuralgia, either because of direct injury or an entrapment of the nerve. The hernia recurrence is always a possibility. Hydrocele, varicocele and a spermatocele can give rise to similar pain, and sometimes a myofascial injury related to the surgery can present as inguinal. After having a lot of differential diagnosis for this patient, we need to make a diagnosis depending on the history of the surgery. Second thing is the presentation of the pain. It is along the inguinal region and the groin. Electromyography may be needed, and a high resolution ultrasonography can reveal whether the nerve is continuous or not. Before we try to trace the nerve a little proximally at the level of the flanks between the internal oblique and the transverse abdominal muscles, you need to understand what is the anatomy of the ilioinguinal nerve a little bit. The ilioinguinal nerve is actually a mixed nerve originating from the anterior rami of T12 and L1 nerve roots. It emerges near the lateral border of the psoas major and goes a little inferior through the abdominal wall, being subperitoneal and anterior to the quadratus lumborum until it reaches the iliac crest. So when you try to look at the flanks, it may be just located beneath the internal oblique and above the transverse abdominis muscles. Trying to trace the muscles proximally and distally, we need to understand that this nerve can be either hydrodissected or a pulsed RF can be done at the level of the flanks. You could see there is a small little artery there. That artery is the deep circumflex iliac artery, and on either sides you have the ilioinguinal and the iliohypogastric nerves. This is the anterior superior iliac spine for you. So these are the prerequisites for doing the intervention. A standard monitoring with ECG pulse oximetry is required. Do this procedure only in the operating room with the following drugs: a preservative-free lignocaine 1%, steroid, triamcinolone, a particulate steroid may be used. 5% dextrose can be used for hydrodissection of the nerve if there is an entrapment. And these are all done with an ultrasound machine using a linear transducer with MSK preset around 2 to 3 centimeters depth. So the best ergonomics will be the patient in between the interventionist and the machine. Keep the patient in supine position with the abdomen, groin and the flanks exposed. Trying to trace the nerve, you need to expose all these areas. So how do you really plan your intervention? Do a proper nerve tracking. Identify the site of entrapment, which is always the site of incision. You can either use a steroid injection or a 5% dextrose for injection. It can be a diagnostic cum therapeutic block. When the pain recurs, you can either repeat the dextrose injection or a radiofrequency ablation may be planned. If it is a little proximal, you can do a pulsed RF. If it is a little bit distal, you can either do a pulsed or a conventional RF for better results. So this is how exactly you perform your procedure after sterile preparations of the area and the probe. Try to keep the probe on the flank, trying to see the proximal course of the nerve. If you really want to look for the course of the nerve along the spino-umbilical line and this line, you can actually do a scanning with a linear transducer with 2 to 3 centimeters depth in the PMSK preset. Try to give a needling close to the anterior superior iliac spine so that you see the needle in plane. Difficulty may be faced when you do the needling at this area because there will be a higher riding anterior superior iliac spine which will preclude proper needling technique. This is where exactly the anterior superior iliac spine was lying. Since it was a higher riding bone, I just tried to translate my probe a little inferiorly. A little distal portion of the nerve was to be visualized. And then I did a in-plane technique needling to do a hydrodissection of the ilioinguinal nerve with 5% dextrose. So a couple of important landmarks here, that is the anterior superior iliac spine. You could see the internal oblique muscle there, and there is the artery, deep circumflex iliac artery, and either sides you have the ilioinguinal and the iliohypogastric nerves. The nerve may not be visualized in a patient who has undergone a hernia surgery. We can trace the nerve a little proximally with an important landmark, that is the posterior circumflex iliac artery. At the level of the flanks, this is how the image looks like. The external oblique, the internal oblique and the transverse abdominis muscles. The plane which contains the circumflex iliac artery, the ilioinguinal nerve and the iliohypogastric nerve is the plane between the internal oblique and the transverse abdominis muscles. At the level of the flanks, if you really try to do a nerve block or a pulsed radiofrequency, this is how exactly it is done. The needle is inserted in an in-plane technique using a linear transducer to enter this particular plane which contains the artery and the nerves. When you get a loss of resistance, when you enter this facial layer between the second and the third layer of muscles, try to hydrodissect the plane with 5% dextrose, and you could see the real-time spread of the 5% dextrose in this facial plane between the second and third layer of muscles. In this patient, I have done a hydrodissection at the level of the flanks using a 23 gauge spinal needle. At the flanks, I have given 5 ml of 5% dextrose into this facial plane between the internal oblique and the transverse abdominis. After injecting the 5% dextrose at the level of the flanks, you could see the real-time distribution of the 5% dextrose there. Then I have performed the hydrodissection at the level of the anterior superior iliac spine as well. See that the spread is along the interfacial plane. You could see at the level of the anterior suprailiac spine, I'm doing a hydrodissection here. You could see the nerves getting delineated. That is the ilioinguinal and this is the iliohypogastric. You could see the pulsatile artery there. That is the deep circumflex iliac artery. You could see the facial plane getting separated. That is hydrodissection of the ilioinguinal nerve at the level of the anterior superior iliac spine. Here again I have used another 5 ml of 5% dextrose. After these couple of injections, assess the pain score by numerical rating scale. Before and after the intervention, the patient developed near 90 to 100% relief of pain immediately after the procedure. The patient was kept for observation for half an hour inside the OR, and ice pack was to be provided at both the needle sites for needle related pain. Post procedure, the patient was prescribed paracetamol for a couple of days. Ice pack at the needle site was continued for 5 days and the patient was reviewed. So what are the clinical pearls? A diagnostic cum therapeutic block with a steroid is of immense value prior to actually planning any neuromodulation technique. Use only 1% lignocaine for better sensitivity and specificity of the block. A neuromodulation can be done when the block is done a little bit proximal because this is a mixed nerve which always supplies some motor branches to the internal and the external oblique muscles. The dextrose versus steroid is always a debate. Dextrose provides entrapment release, whereas steroid is always an anti-inflammatory. So either of which can be used for injection in entrapment or injuries related to ilioinguinal nerve. So the patient outcome, more than 75% of pain relief was there after 2 weeks of the hydrodissection with 5% dextrose. He was planned for another sitting after 2 weeks. Pulse radiofrequency may be required if there is any residual pain. Thank you.